I'm going to try to give us a sort of whirlwind tour of some of the advances in radiology and imaging. So glimpses here and there. Just to start off, I only have one disclosure. I serve on the board of directors of Image Metrics, which is a for-profit arm of the American College of Radiology, and serve as an unpaid consultant, but occasionally they pay to have me go to the board meetings. And I'm on a lot of things that I don't get paid for, as I'm sure many of you are. And I also spend most of my life doing imaging, both at work and outside of work, and serve as the president of C.C. Meltzer Photography, which is my organization that supports my fine arts photography career on the side. So I'll end with one of my pictures. But want to take you through a little bit of a historical perspective of radiology, some of the key advances in imaging, and something near and dear to my heart, multimodality imaging, and talk a little bit about image-guided therapy as well. Imaging biomarkers, the role of imaging in screening for disease, and there aren't that many instances where we've used imaging successfully for screening, but certainly there are some, most prominently mammography. Talk a little bit about the digitization of imaging and the evolution of imaging research. So I'd like to think about the central driving challenge for medical imaging. It's threefold. One, in terms of the diagnosis. We're always looking to non-invasively detect disease at the earliest possible stage, and to use that information for prognostic or predictive purposes to guide patient management and care planning. And then more and more, radiology is incorporating therapeutic approaches with image-guided, targeted therapies that are becoming more and more specific, increasing efficacy of treatments with lower morbidity and mortality when compared with more invasive approaches. And then I think there's just a central drive by all of those involved in imaging, by this drive to just be able to look within, to understand the human body, both anatomically and functionally. So it all started with Wilhelm Röntgen many, many years ago in the discovery of X-rays. But when we think about it, from that early time until the 1970s, radiology was a pretty boring field. I mean, it was just radiographs and fluoroscopy, and really not much else. And they weren't so good at low-dose imaging back then, and I think a lot of these folks who did these early experiments ended up with sarcomas and lymphomas. But the mid-70s really was a major breakthrough that changed the face of imaging and changed the face of modern medicine. And when you survey physicians and biomedical scientists as to what are the top 10 breakthroughs in modern medicine, CT imaging always comes up in that top 10 list. So CT, what was CAT scan, computed axial tomography, or CT scanning, always is very high on the list, and that occurred in the mid-70s. And I have to tell you a little story that's sort of a fun story of what the Beatles have to do with CT scanning and how that came about. Some of you may have heard this before, and some of you think I've lost my mind. But EMI was a small British company and had a branch in the US, and my mother actually was a secretary for a small branch of EMI on Long Island. She had nothing to do with it, but it's just one of those 7 degrees of separation. So EMI also owned Capitol Records and Apple Records that produced the Beatles. The Beatles made a lot of money for Capitol Records and hence EMI. And EMI also had a small branch that worked in electronics. And Sir Godfrey Hounsfield was a scientist working in that branch for EMI. And he got a grant to do some extra project that he was working on called the photomultiplier tube. And some of those extra dollars came his way, and he came up with the basis of CT imaging. So I hope he listened to a lot of Beatles. But we take for granted tomographic imaging, but it was such an exciting concept, the ability to look inside, to slice. So I forgot to bring my orange, but sometimes I bring an orange and I say, the ability to slice something, but then to be having it whole and to be holding it in your hand and to be looking at the inside of it was such a revolutionary concept. To be able to look inside the brain, to look inside the body without a scalpel. So, okay, it wasn't a pretty picture to start out with, but it really was revolutionary. And in medicine, sometimes our image has not always been the best on the first time around, but we improved upon it. And the modern CT scan is pretty darn good. So that also came a long way. In the mid-1980s, when I was in training, along comes MRI. And the first ones didn't look like this either. But that was another revolution. So really having superior soft tissue contrast and conspicuity, so lesion conspicuity. If you hear the word conspicuity, you know the person you're talking to is a radiologist because normal people don't use that term. But it means the ability to look at something and to be able to have a lesion pop out at you and to really be able to detect it with greater sensitivity. And initially the imaging took real long. I mean, you could, let's do 3 MRIs a day. And the cost was quite expensive. And MR safety was not what it is today. We didn't quite understand it. But with newer pulse sequences allowing for faster imaging, the protocols came down considerably to just a few minutes, and then extensive imaging now, including patient prep time and injection of contrast. In our hospital, we have 30-minute slots and trying to move toward 20-minute slots. CT is now down to the time it takes you to put the patient on the table and take them off. That's the rate limiting factor, not the scanning. So here's the soft tissue contrast difference, just to illustrate. CTs are really quite pretty. But here's an MR. This is a proton density weighted image, and you can see very little gray-white distinction on the CT, but beautiful gray-white distinction on the MR. And it's that kind of soft tissue detail that, especially for neuroimaging, my area, makes all the difference. So MR imaging is really the mainstay in neuroscience and becoming more and more relied upon for pediatric imaging and whole body imaging. What MR also did, along with the nuclear medicine techniques, was really introduce functional imaging and really take the radiologist out of the realm of being the anatomist to being someone who focused on also function, physiology, and even earlier disease detection by being able to look at changes that reflected physiology and function even before structure changed. So in this example, here's a diffusion-weighted MR image on the left showing a stroke that's minutes old. Whoops. And then the perfusion image, here's the pointer, and the perfusion image showing in that area decreased perfusion, and then the ability to quantitate that difference showing a delayed mean transit time through that area. So being able to really characterize tissue on which to base treatment decisions, but doing it on the basis of function. And it may be that the CT here wouldn't show much at all at this stage, and even an anatomic MR might not show much. This is a very new image. This is one superimposed on a structural MR spectroscopic imaging. We usually think of spectroscopic imaging as being these sort of little waveforms, but there's spectroscopic imaging now, which gives you a map of the chemical profile, and superimposed on the MR, you can see where that map is. And this is in a patient with a recurrent brain tumor in a stealth system, so being localized for a biopsy. So more and more being able to get at tissue specificity with imaging. And one of my colleagues, he calls himself an MRologist. We tend to be very specialized in academic medicine. Refers often to the virtual biopsy. If we can characterize tissues so well, we don't necessarily always need to biopsy them. We can tell what's going on from the image alone. And we work very closely with pathologists to know when to biopsy physically and when to biopsy virtually. So one of the key advances that's near and dear to my heart is multimodality imaging. As Dr. Devi mentioned, I was involved in the first PET-CT scanner. Somewhat serendipitous moment in my career, but I wanted to describe that a bit. So PET imaging had really been around since the 50s in various forms, but really applied only for brain imaging. And I actually was involved as a first-year medical student. I was, in need of grocery money, so I volunteered for a PET study, and they were doing the first neuroreceptor PET studies at Hopkins, and I volunteered. I got my grocery money, but I kept going back to the investigator and saying, can I see the images? This is really cool. And he said, beat it, kid. But I kept coming back, and then I ended up doing an elective with him, and I got involved in PET imaging pretty early on. And when I got to Pittsburgh, I was involved in the PET center there and went specifically because of that. What was also happening during that time were these advances in instrumentation that allowed PET to be applied to the whole body. So allowing for bed position changes, for fast scanning, to have whole body imaging done. So this was kind of a big deal at the time, and I was working with David Townsend, who's a physicist who was working on this. But he also had another very interesting idea, and PET started to come about as a clinical tool, but the brain was very different than the body. And how do you get FDG, fluorodeoxyglucose, which is the most common agent, particularly for oncologic indications, to be distributed to various centers? So all this was going on. And one of the problems was that PET was very sensitive, small amounts of radioactivity, and it gave this great functional information, but had very limited anatomic information. So depending on where you were in the body, the brain took up lots of glucose anyway, so you could see where you were. But in the body, sometimes you'd see these areas of uptake, but you didn't know where you were. So very little anatomic information. So combining PET and CT was the critical concept that David Townsend was working on. So the idea was that structure and function would be combined, and would that really help us out, telling where lesions were? So we paired up on this, and I oversaw the clinical evaluation of the first patients on the prototype scanner. And the critical question for us was, what % of the time did this combined technology perform better than PET alone and having a CT scan that patients came in with? And how often did that change the management? And, as we first started getting experience, we said, if it's a pulmonary nodule, we just want to see if it takes up glucose or not, and that's pretty easy. We just need a PET scanner for that. So, we think we know how this is going to go. We're going to be able to just take the complicated cases and take them over to PET-CT, and take the easy cases, and they'll just need PET. But as this study went on, we realized increasingly we couldn't tell which patients were going to benefit from the combined technology. I'll just share a couple of these cases with you. Here's a patient who had the misfortune of being a VIP. So actually, it was the brother-in-law of one of our chief techs. So instead of being in a quiet place during the uptake phase, or inject the FDG and they sit quietly, he was chatting with everybody. And he was someone who had lung cancer, had a pneumonectomy, and well, you'll see from there. So here's an area through the neck, and it's a little bright up here. Radiologists always have their rooms really dark, so you can see the images best, but can't see anything else. So anyway, there's a little area of uptake in the neck, and you can't see much of anything else, and that's true in the image. And we said, gee, there must be a node, there's a recurrence, what is that? So we had him in the PET CT scanner, and we said, oh, well, that overlies his vocal cord. And it's on the opposite side of things. And it's the opposite side of his pneumonectomy. And oh, by the way, on the CT scanner, we can see that his vocal cord on that side is paralyzed, probably from the surgery or his original tumor. And gee, he was chatting the whole time during the uptake phase. So that's just benign functional uptake. And he was scoped just to be absolutely sure, but we saw that finding again other times, and we never had to scope the patient again, and we tried better to keep them quiet. But in other cases, this was more typical. Patient with cervical cancer, here's a whole body image with PET, and the FDG is taken up, is excreted through the kidneys and excreted through the ureters and bladder, so bladder uptake's pretty common. And we sometimes see a little bit of ureteral uptake as it comes into the bladder. So, gee, there were a couple of dots there. It looks like the usual ureteral uptake. But here you can see on the CT that it actually corresponded to 2 sub-centimeter nodes. And so that made the diagnosis. On CT alone, it wouldn't have made the diagnosis. The nodes were very small, non-necrotic, but with the combined imaging, it upstaged the patient's cancer. So in this early experience, over a large range of tumors, we really found that it seemed to be about 20% of cases that it really made a difference in the management of the patient, but we couldn't tell which 20% going in. And it really made a difference, particularly in trying to tell physiologic FDG uptake from tumor, evaluating these non-specific or small CT findings, and localizing disease for biopsy and treatment planning. And we did some more sophisticated studies afterward in areas that were really tough, like head and neck cancer. And my colleague, Char Brandstetter, was the first author on this publication where we looked at an ROC curve for CT alone, PET alone, and PET CT in recurrent head and neck cancer. And the PET CT performed with higher accuracy. So this was our moment of fame, and the PET CT prototype was Invention of the Year in 2000 in Time magazine. So there's a story in this Time magazine about that, and we have some quotes in there, but nobody actually read this article because there was a little distracting story on the cover. So we sort of got out-trumped a little bit by some things that were going on politically. So PET CT took off. It's now part of mainstream medicine. PET CT sales went up. PET is pretty much, single PET is only used primarily for brain imaging research at this point, but otherwise it's pretty much tied to a CT scanner. So I'm not the brightest radiologist you'll ever meet. I never worked as a consultant for Siemens, even though I did this work, and never bought any stock. So, live the pure life. Okay. And to MR PET prototype is what's come out more recently, and Emory was among 4 sites. 4 university sites, 2 in Europe and 2 in the US, then had this original prototype over the past few years. It was a head-only machine with 3T trio, MR, with a PET insert. And a little bit kludgy initially, but we enjoyed having that experiment. There is now an integrated, and this is a Siemens system, there is an integrated whole body MR PET system now that's at several sites. And people are getting their initial experience with that. Now, one thing that's different about MR PET over PET CT, and people seem to be very specific about PET CT, the PET goes first, and MR PET, the MR goes first. And I think it has to do with that the company, which group has control over the project. So I've got to be careful because I don't want to offend them. But this is MR PET. This has simultaneous PET and MR imaging, where PET CT is consecutive imaging. So this does offer some interesting possibilities for functional imaging with imaging at the same time, especially if you're looking at brain imaging. Now, PET and MR have different temporal resolutions inherently. MR has the ability to have much faster sampling of physiologic processes. But still, being able to image the brain in the same physiologic state brings to mind several very interesting research uses. Being able to look at the blood flow state and the temporal resolution of perfusion, diffusion during stroke, epilepsy, et cetera. So these are possibilities, but we're at the very beginning of this kind of work. In the body, there are other possibilities. But really, MR PET is in search of a killer application, whereas PET CT has really taken off to be part of mainstream medicine for oncologic work. So another key area of advances, image-guided therapies. If it were so easy, I couldn't possibly do justice to the area of image-guided therapies. This has become a large area of radiology, and it is almost as if there are two populations in radiology departments, those who do diagnostic imaging and those who do image-guided therapies, and people live for one or the other. But there are increasing options using imaging for guiding therapies, everything from draining and biopsying things to really very sophisticated therapeutic approaches to cancer care with ultrasound, CT, MR, catheter delivered drugs, radiation. There's a large group at our center that is very involved in cancer image-guided therapy, especially radiofrequency ablation and also other ablative techniques for liver metastases and other metastases, where they use image guidance to put probes in tumors and then deliver some kind of high energy in a distributed manner, and have shown lower morbidity, longer survival, and very good results. We also have been very much involved with a collaborative project between our interventional radiologists and our nuclear medicine team in delivering yttrium beads to liver tumors. And this has to be done in a very coordinated way because yttrium has a long half-life and needs to be handled in a very careful way. But this has also been a very successful approach. And here's a PET CT of a patient with breast cancer who had liver metastases, and then 6 months following this targeted yttrium therapy shows no FDG uptake in the liver. And this is our team of David Schuster's head of nuclear medicine and Kevin Kim, head of interventional radiology, two very innovative physician scientists. We also have started a program that doesn't exist at many centers in interventional MRI. And this is not an inexpensive program to start. You can imagine that the instruments you have to use all have to be made in a special way to be safe in the MR environment. And the procedures take a long time. Sharif Noor, who came to us from the Cleveland, Case Western in Cleveland, has trained at Hopkins in this technique, and he's doing a number of interesting therapeutic procedures, including placing electrodes for deep brain stimulation in the brain using interventional MRI. And so interventional MRI is being increasingly used in the whole new field of neuromodulation. So the next area I wanted to talk about is biomarkers and screening techniques for disease monitoring. So how are imaging biomarkers different from other biomarkers? I mean, we can use serum biomarkers and genetic biomarkers. Imaging biomarkers do have the advantage of having the specificity of localization, but like other biomarkers, must meet the criteria of being quantitative, sensitive, and reproducible. And we look to these biomarkers to take us back up the healthcare curve a little bit more to the left. So our current medical practice tends to focus down here in clinical disease, and in fact, if we look at cost curves, quite a bit much in end-stage disease. Trying to push that up to look at secondary prevention strategies for dealing with earlier disease states or subclinical disease states, and even in primary prevention for primary screening. Now, we don't have as much in the way of screening as we might like to at this point. But certainly mammography is an area where screening has proven to be cost-effective and clearly efficacious, even though there's a controversy every few years about the exact age cutoff at which we should start mammography, but clearly a proven tool for early disease detection. And the majority of women who acquire breast cancer have no identifiable risk factors, so this is a primary screening procedure for the most part. Now, what I think most people don't understand is the challenges of mammography, is that there is a pretty high false negative rate, and that only about 90% of breast cancers are mammographically detectable. So there can be difficulties with very subtle lesions because of the superimposed and overlapping tissues. It's not an inherently tomographic technique, like most other imaging that we do. You can have superimposed normal tissues that give you a false positive if they're just in the right way, and certainly women who have dense breasts have more difficulty. And the whole way we practice mammography screening is not particularly patient-centered. We call back women when we're not sure of something. We screen them, read them later in batches, and then call them back to have additional views. That produces extensive anxiety in patients. So the whole way we do screening mammography in this country is not ideal. I've had the privilege of working with Carl Dorsey, one of the giants of breast imaging. And if there's one person who is obsessed with finding better ways to image breast cancer, it's Carl Dorsey. He can be very strong-willed about a lot of things in his path to do that, but he is all about the patient. And one of the things he's been working on has been tomographic breast imaging with low-dose cone beam CT. And I'll show you just if it works, because it always works when I practice it up here, but not when we have a live audience. But let's see if we can get this video to work. But this is a tomographic image where you see the skin pulled away. So post-processing is involved here. Oh, okay, let's try one more time. All right. There we go. Doesn't help that I'm a Mac person. I did. There we go. Okay. So that's a little bit different than the standard 2D mammogram. Now you can see the superimposed tissues all fall away, and you can see exactly what you're looking at and where the lesion is as opposed to normal breast tissue. So this kind of work is very exciting. Also, breast MR, which now is in clinical practice, is also another tomographic technique. It's not been approved for routine use and has been used more for high-risk cancer. Yes? Was there a lesion there? Yes. There was a lesion there. I don't know if I can get to do it again, but it was this.
Left click on the play. The click button.
I got it. Right. Don't touch it. Now, I don't... I'm a neuroradiologist, so you don't want me reading your mammogram, and I promise I won't, but I believe there is a large lesion there. It looks a little bit like the brain. Whereas breast MR, another tomographic technique, is used for high-risk patients in very specific circumstances, but has a lot of false positives. And part of this may also be in getting experience. When brain MR came out, we called every little white dot something, and there were papers written about these dots being associated with migraines, with everything that was common. They really didn't mean much. So the same with MR, a lot of false positives, but people are getting experience with it, but it probably won't be a screening tool. It's also expensive for that, but certainly helpful for high risk and for evaluating specific lesions. Now, another screening technique that's very new and very exciting, I think, is low-dose lung cancer screening with CT. And this came out of the National Lung Cancer Screening Trial that compared low-dose helical CT with chest radiographs. And we were one of the sites for this. It was a 10-year trial, but they stopped it early. And this trial looked at heavy smokers, very specific criteria, over 55, heavy smokers. In November 2010, they released the findings, stopped the trial, and said there was a 20% lower risk of dying for those who were screened with the low-dose CT as opposed to chest radiographs. So now a number of sites are using the criteria in the trial, over 55, heavy smokers, certain number of PAC years, and using low-dose CT for screening. We've set up such a clinic ourselves. The Lung Cancer Alliance, which is a patient advocacy group, has a website and lists the universities and medical centers that have set up clinics that are using the criteria and doing so in a quality manner. Now, a biomarker trial, this isn't yet in the screening area, but actually sort of an interesting thing happened just this week. Biomarker I wanted to mention that's in an area that I've done some work is in amyloid PET imaging for the detection and evaluation of Alzheimer's disease. Now, one of those amyloid PET tracers, AV45, was just approved by the FDA this week. And it is very significant because the FDA approves a PET tracer about once every million years. I mean, there's really FDG and there's just about nothing else in the brain. So this has been long anticipated and people wondered if it would ever happen. So it's a huge celebration of, in the PET world and in the neuroscience world, that the FDA actually did approve this tracer. And amyloid tracers are a good target potentially for secondary prevention strategies in a high-risk group of elders with mild cognitive impairment. a high-risk subgroup of folks who have memory problems, don't meet criteria for Alzheimer's, but convert at a rate of about 15% a year, about 50% over 5 years, but not all go on to Alzheimer's. So a very interesting high-risk group. And we always learned that Alzheimer's disease was a diagnosis made upon autopsy. That's not a very patient-centric approach, but it is an easier diagnosis to make on autopsy. So what if we could image exactly that, the cerebrovascular amyloid and the plaques and tangles, or at least the plaques, without the pathologic tissue, but in the brain of a living individual. And this was the work of Bill Klunk and Chet Mathis at the University of Pittsburgh's PET Center. And they developed the Pittsburgh Compound B, which is the sort of the compound that was used for all of the proof of principle studies upon which AV45 and some of the other newer agents were developed. So here, much easier for this patient, rather than to have an autopsy, but to have this PET scan and show that this patient with Alzheimer's disease has lots of uptake. The control image with the Pittsburgh compound, no uptake. Here, we've imaged a patient, a normal control, and a patient with mild cognitive impairment. Their MRIs look similar. They're both elders. Their FDG PET. FDG can detect Alzheimer's disease and shows biparietal, bitemporal hypometabolism, but not so good in the earliest stages of disease, so not very sensitive in mild cognitive impairment patients. Whoops. But here with PIB, this individual with mild cognitive impairment had uptake, suggesting they're going to go on to develop Alzheimer's sometime within the next 5 to 10 years. Oh, thanks. Okay.
Let me put this on you for a second because you're turning back this way and I'm losing some of the audio.
Okay.
Just to hear you a little better. One second.
I usually can speak louder, but the pollen in Atlanta has gotten to my voice. The next thing I wanted to mention is the digitization of radiology. So the way you would transfer a plain film radiograph from one individual to another was you would hand them a film before digitization. That wasn't very efficient. Certainly didn't lead to being able to share widely images, being able to quantify them, data on the images. And CT was really the first digital imaging technology. Pretty much now everything is digital. So plain film radiographs are acquired in a digital manner. They're no longer acquired, for the most part, using films. They're acquired through a digital technology. Mammography is now going digital. Everything is digital. So there is the ability to quantify, share, distribute, post-process image data in a way that you couldn't before. So no more film, only digital. Remember, I like cameras. So this digital age has permitted us to have a completely distributed workflow. Some of that isn't so good and has some negative connotations, but really being able to, through PACS and RIS systems, distribute our workflow, be more efficient, and share images across town, across the country, and to be a completely paperless environment. And although not always as seamless as we'd like, integrate images into electronic health records. Post-processing, 3D visualization, all of that is possible. And to quantify and compare images across time points. It's also allowed for a lot of data. So with the slide, I think I broke the microphone now.
Oh my goodness.
Wow. Has anyone ever done that before?
Not usually.
Okay. All right, I'll just talk in here.
Not recently, actually.
Okay.
Okay, how about Put it
I'm getting
on
personal
the
here.
belt itself.
All right.
Getting personal.
All right, got it. It works.
Just pretend I'm your doctor.
Okay. Okay. More recently, the slice wars that they had with CT, multi-detector CT, has led to thinner and thinner slices and decreasing the noise of CT images. And with all of the pulse sequences and functional imaging that's going on with MR, there's so much image data. And we get all these great, pretty pictures, but there's been an exponential growth in this data. So if you see your radiologist having tremendous eye strain, and those of you who are neurologists, if you're treating more headaches, there's a lot of that. So there's a lot of fatigue from this. And actually, this was a study that was done looking at the radiologist's time in if there were thin slice images that had 170 images or a study that had 246 images and the time it took them to read it. So we're just piling on images. And 246 images in a single study is not a lot these days. And when I think about when I was in training and a CT had 10 images on one sheet, and that was your CT scan, and now it's just, just images after images. It's a lot of data. So there's always also the RAM and the storage capacity you need for that, but the eyes of the radiologist as well. Digitization also allows you to be more portable, read images anywhere. I guess your radiologist theoretically could be on the golf course. If you see any of my radiologists on the golf course, I want you to let me know. But it also allows for a flattened world. So we now have 6 hospitals, and we can transfer images around. GR head and neck expert is at this hospital today. We'll send this hard case over there, et cetera. It also helps with the global health as well. Radiology is now getting into global health in a way that wasn't possible before when our equipment was too big and too kludgy and too technical. So now we can see highlights from everywhere. And I just wanted to talk for a moment in closing about imaging research. When I entered radiology, and I had been very research-oriented, clinical research in radiology was largely descriptive. So articles were about the appearance of something on CT, the appearance of something on ultrasound. So with the advance in technology, with the new tools, especially with functional imaging and molecular imaging, it's exponentially developed not only radiology research, but imaging in every discipline. And initially, a lot of this was focused in application areas in neuroscience, so extensive functional imaging in neuroscience, but then a lot of those techniques as applied in neuroscience went into other application areas as well. And 10 years ago, exactly, because I have this date on my calendar, in June, the National Institute of Biomedical Imaging and Bioengineering was developed. Rod Pettigrew is a faculty member at Emory, is the founding director, and is still the director. The solo director is there for 10 years. This institute was devoted to merging the physical and biological sciences to develop new technologies that improve health. So it was very interesting that they put imaging and bioengineering together. So it's focused not only on technology, but also on so not only on imaging, but also on the technologies that can produce new imaging techniques. There's also a new focus for all of us on implementation science. And imaging fits in well in some areas we need help with. Comparative effectiveness, there are all these technologies. We tend to like to, let's do a CT and an MR on that patient, and then a CT and then an MR, and we did the ultrasound first. But really looking at comparative effectiveness for what we should do as a singular test, introducing decision support with appropriateness criteria that we've developed through the American College of Radiology and with other disciplines to support doing the right thing for the patient, the right imaging study at the right time. radiology informatics to be able to handle all of this data in a seamless, integrated, and digital environment. So we know all about going from basic science to translational science. That's been the buzzword. And translational science being application specific, the valley of death to cross that, to get to human studies. But there's a lot that gets stuck in translational science and isn't actually applied and implemented in the clinical environment. And I've named that the chasm of doom because I thought it needed an equally ominous bridge term, and nobody took it first. But implementation science is the big buzzword, and that's been introduced by Ann Bonham at the AAMC for really innovation that goes to improved care, delivery, access, and there are new funding sources for that, such as PCORI. So looking ahead, here's the blueprint for the next 1,000 years. It's very complex and involves a lot of technology and formulas and a lot of physics. But I don't know where we'll go. There's one of the reasons I went into this field is because the very rapid growth in technology every day is something new. So I'm sure what we do today will, what we do tomorrow will look like nothing like what we do today. So thank you so much for your attention. I'm happy to answer any questions.
Spend some time talking about how you got to where you are to the students.
Sure. Yeah. Let me answer your question.
Just, and I want to preface my statement by saying I really enjoyed your talk and all the advances that have been forwarded in diagnostic imaging. I am one of the centers that launched this lung cancer screening. And let me just share with you from a clinician point of view the disappointment that we have.
Oh, uh-oh. Okay. Tell me.
I am involved actively in the implementation from neonatal to infrastructuring to implementation of the program. I have problems with the fact that when we do the CAT scans to screen patients, we detect all other problems, and that opens up a box of Pandora.
You see additional findings?
Yes, and more disappointing is the radiologist will get back to you and recommend XXX number of CAT scans for XX number of years, along with another PET scan.
Not good. Not good.
And combine that with reader variability.
Yeah, you need a partner who is invested, and a cardiothoracic radiologist who is invested in the program and leading the program with a pulmonologist. That's the way we set it up. And one of the important things is to make sure that such a clinic is not, has very tight criteria. So it has the same criteria as the National Lung Cancer Screening Trial. Because one thing that didn't work, and that was when CT scanners were put in malls to do these whole body screening things, and all these false positives came up, all these things that needed to be worked up, this slippery slope. And nobody wants to repeat that. So it has to be really narrow criteria, just what the National Lung Cancer Screening Trial. We've worked out a very detailed protocol, and I'm happy to share it.
I'd like to have that. The
Okay.
other thing is...
Give me your card, and I'll share it with you.
Certainly. The other thing is when we discuss PET scanning for diagnostics, let's say staging, sometimes we don't inform the referring physician that there are pitfalls to the PET scan, that everybody just follows the recommendation you need a PET scan. Sometimes what you need is to get the tissue and not go through the PET scanning, and that should be relayed. That's my comment.
Yesterday, I gave a talk at Baptist on fragmentation of healthcare. Sounds like it's part of what we have. We still have a lot of it.
Dr. Meltzer, I have to say, this is mind-boggling. 30 years ago when I was in medical school, this was all futuristic medicine, and I'm so happy that we're living it. I'm an anesthesiologist, and I certainly benefited from radiology. I'm doing ultrasound-guided techniques for my pain nerve blocks and for my vascular access. My question is one from a layman's point of view. We do a lot of surgical procedures wearing these big, heavy lead gowns and the thyroid shields, and sometimes we're in the hospital doing that for 12 hours. Is there any thrust in studying further researches in lead that's not heavy to protect the people who work?
So new lead is much less heavy than the older lead, and what's really important is lead to fit you. So what usually happens in a hospital is they get lots of the big ones for the men, and then the small women come around and they end up wearing that because that's all that's there.
Really wears you down.
But what we do in our department is go size the principal folks specifically so that there are sizes for everybody, and someone my size doesn't have to wear long, huge, heavy lead. And then the new lead is much less heavy. And they also, you don't want the ones that are just long in the front because they really hurt your back. You want like something that's a skirt or something that's evenly weighted a little bit more. And the new lead's much better at that. It's much more ergonomic.
No synthetic lead yet in the picture. Thank
So
you.
go tell whoever orders to talk to the radiology administrator.
My question is, patients who are coming in and
It's up to you. Sorry. Okay, sorry. I'm sorry.
I was going to ask you that. There are patients who come in asking for alternatives to mammography. They are against mammography, whatever reasons. You convince them that we're using digital, but they're asking for tomography, the color imaging methods. And I think that we used to have them in the earlier years, but can you comment on that?
Are you talking about breast tomography or
For the breast,
of the breast?
yes.
Breast tomography, it didn't touch on that. That's another technique that's being used as an augment to mammography, and it's available some places, and it's very promising as well. It's plain film tomography, though.
Where is it available? Because I don't know where to guide the patients.
I don't know where it's available. Many of the newer machines are tomographically capable now, because there's just been a big study of breast tomography that's been promising.
Okay, so we